All right, let's jump right in. Today, we're looking at an organism that every single clinical microbiologist needs to have on their radar. It's a real classic, and it comes with a major clinical curveball. You know the drill. You get that call, gram-positive rod growing in a blood culture. And that first instinct, that go-to for empiric coverage, is almost always vancomycin. But what if I told you that in this case, that choice is not just a little off, but completely intrinsically wrong? Just keep that thought in your back pocket. Because today, we're talking about Erysipelothrix Rhusiopathiae. This is the bug that makes that exact clinical scenario so tricky. Now, to pull all this information together, I've used a Gemini deep search. And if you want to see all the primary sources and citations, you can find the full list in the notebook that's linked right down there in the description. So here's our game plan. We're going to take a bench-to-bedside journey, starting with the basics of the pathogen, then diving into how we nail the ID in the lab. After that, we'll look at the clinical syndromes, talk treatment, which is crucial, and wrap up with prevention and control. Okay, first things first, let's get to know this organism. Where does it come from? What's its story? Because really, this is all about the close connection between animal health and human health. So what exactly are we dealing with? Well, Erysipelothrix Rhusiopathiae is a facultatively anaerobic, gram-positive bacillus. It doesn't form spores, but its real claim to fame, it's a classic occupational pathogen. So you should be thinking about people like butchers, vets, fishermen, anyone who handles animal products. It's almost always picked up from animals, and pigs are far and away the most important reservoir. You know, the history here is a pretty cool microbiology detective story. It starts with Koch and Loeffler finding it in animals, but the real breakthrough for us came in 1909 when Rosenbach isolated it from a person. And he was smart. He called the lesion Erysipeloid to make sure no one confused it with Erysipelas caused by strep. It actually took until 1966 for it to get the official name we use today. All right, let's head to the bench. For all the microbiologists watching, this is where we can really be heroes, because this bug has a few little quirks that can easily lead you down the wrong path if you're not paying attention. And here is trap number 1, the gram stain. Erysipelothrix Rhusiopathiae is a skinny little gram-positive rod. Sometimes it even looks filamentous. But, and this is a big but, it is absolutely notorious for decolorizing. So if you're not careful, you might look at it and call it gram variable, or heck, even gram negative. It is such a critical bench pearl to keep in mind. Now, on a plate, it's not too picky. It'll grow on your standard sheep blood and chocolate agars, and it does like a bit of extra CO2. What you're looking for after a day or two are these tiny, pinpoint, almost transparent colonies. Sometimes you'll see a little hint of α-hemolysis. Oh, and you might see 2 different colony types. A smooth form, usually from acute cases, and a rough form from chronic infections, which usually looks more filamentous on the gram stain. Okay, telling this apart from other common gram-positive rods is obviously key. So first up, it's catalase-negative. That right there helps you rule out Listeria and most Corynebacterium. It's also non-motile. But the real showstopper, the one test that will make you say, aha, is right there in bold. It produces H2S on a TSI slant. You'll see that classic blackening. That is your money test. Of course, in the modern lab, we've got some faster toys. MALDI-TOF will give you an ID from a colony in like minutes. It's fantastic. And there are also species-specific PCR tests that can pick it up directly from a tissue sample, letting you skip the culture process entirely. Okay, so we've found it in the lab. Now let's switch gears and look at what it actually does to people. What does the infection look like? This is where everything we've just talked about really starts to matter for the patient. The disease really presents in one of 3 main ways. The one you'll see most often by a long shot is a localized skin infection we call Erysipeloid. Way less common is a diffuse skin infection, and then in the most serious and thankfully rarest cases, you get a systemic infection where the bacteria gets into the bloodstream. And this right here is the textbook presentation, the Erysipeloid of Rosenbach. It's the super distinct skin lesion, usually right where the person got poked or cut, so think hands and fingers. It's described as this purplish-red, well-defined plaque that spreads out slowly. Patients will tell you it burns and itches like crazy, but the absolute key diagnostic clue that separates it from something like strep erysipelas, there is no pus. None. No suppuration. Now, when the infection does manage to go systemic, the situation gets serious fast. The biggest fear is endocarditis. And when Erysipelothrix Rhusiopathiae gets onto the heart valves, especially the aortic valve,
it is incredibly destructive. We're talking about a mortality rate that can approach a staggering 40%.
And that brings us right back to that question from the beginning, and honestly, the most critical part of this whole discussion: treatment. This is where knowing your microbiology can literally save a life.
So here it is, the big reveal. The antimicrobial profile of this organism is incredibly predictable. It is almost always susceptible to penicillins and cephalosporins. On the flip side, it is intrinsically 100% resistant to vancomycin. I want to be really clear. This isn't acquired resistance. The organism just plain lacks the molecular target for vanc. It just doesn't work.
And because its profile is so predictable, treatment is thankfully very straightforward. For that simple skin lesion, Erysipeloid oral penicillin V is perfect. If you've got systemic disease or, heaven forbid, endocarditis, you escalate to IV penicillin G, and for endocarditis, you treat for a lot longer. And while it's not common in kids, we've got the weight-based dosing here just in case.
I love this quote because it perfectly explains why you won't find specific UCAST breakpoints for this bug. It's not that they forgot. It's because the susceptibility to penicillin is so incredibly reliable that doing routine testing is just not necessary. The fact that there are no breakpoints is in itself a form of antimicrobial stewardship. It's basically telling us, hey, just use penicillin, it works. All right, let's wrap up with our final section. How do we prevent this infection from happening in the first place? This is for folks in high-risk jobs and, of course, for us in the lab. Because this is an occupational disease, prevention really comes down to some good old-fashioned common sense. The number one thing? Wear good, tough, waterproof gloves. After that, it's just basic hygiene. Cover up any cuts you already have, wash your hands well after you handle animal products, and if you do get a cut on the job, clean it out right away.
And for all of us in the lab, this part's non-negotiable. Erysipelothrix Rhusiopathiae is a risk group 2 pathogen. That means all work, every single time, has to be done following standard biosafety level 2 or BSL2 practices. And for any procedure that might create an aerosol, you have to be working inside a biological safety cabinet.
So let's boil it all down. What do you absolutely need to remember? 1. It's a classic occupational disease from animals. 2. In the lab, that H2S on TSI is your key identifier. 3. Clinically, be terrified of endocarditis. 4. Treatment is simple, penicillin. And 5. The biggest takeaway of all, it is always resistant to vancomycin.
And that is our deep dive on Erysipelothrix Rhusiopathy. If you found this useful, definitely subscribe to the channel for more explainers like this. I would absolutely love to hear from all the other microbiologists out there in the comments. Tell me about your experiences with this bug or drop any questions you have. Thanks so much for watching.